Remove the bookmarks. That's fine. How y'all doing?
I need to know, is the Minnie Mouse pose?
Oh, yeah.
I love it.
Oh, yes.
It's me and my crafty self. You know, they call me crafty. We'll just travel together.
Alrighty, guys. So I'll go ahead and get started. It's 12:11. So thank you everybody for coming to my presentation. I know we've broken up into different groups, but my name is Jimmy Pruitt. I'm an emergency medical and clinical pharmacist. I am based out of CMC, Maine. I've done some work out in Grady Health System down in Atlanta. I did my training, stayed on for 4 years. I've built services at MUSC in Augusta University. And I spent most of my time dealing with a multidisciplinary group of people. So I've trained nurses, physicians, and I've been part of training nurses, physicians in pre-hospital care. So I want to talk about something today that's a little different. And before I jump into it, I really want to get a sense of the room. So if you're a nurse by training, can you raise your hand for me? A physician, mid-level, any pre-hospital people? Perfect. Any flight crew that's here? Perfect. So we got a mixture of different individuals that's going to be here today. Again, we're going to really focus most of our time talking about vasopressors, and I'm hoping by the end you get a sense of what I would like. So from a presentation perspective, I have no disclosures, no honoraria, and these are opinions of me of my own and not of Atrium Health or any other individual involved with this. And I'll let everyone get seated. So for learning objectives today, I have the super detailed one for accreditation, then I have the things that we're really going to chat about. We're going to do a review of some physiological rationale. We're going to go ahead and discuss some key studies. We're going to compare some vasopressors, and then we're going to go into identifying the risks. And I would argue that the last section, I think everyone here understands the risk that's going to be associated with vasopressors, particularly when talking about the use in trauma and hemorrhagic shock. So I like to start every presentation off of why this actually matters. And one of the biggest things is that 30% of trauma and deaths are going to be related to early hemorrhagic causes. And a component of that particular type of shock, about 15% of it is going to be vasoplegic in nature. So it's not going to be just the fact that we're losing a lot of our blood. There's going to be some other mechanisms that's going to be happening that's going to cause us to have hypotension. There's always going to be an increase in transport delays. I believe half of the room earlier is going to be in pre-hospital. If you're going to be in a rural area, getting to a main trauma center may be challenging. So this potentially brings another topic that another agent you can have in your toolbox. And there's some new data. And I would say newer, within the last 10 years or so, we've had a lot more questions that's been answered with our data that I'm happy to have. But I'm gonna be honest with you, I'm not satisfied with that. And I would love to do a lot more. But I'm pretty sure my trauma individuals from CMC does not want another randomized controlled trial. So I will hold off for another year. So some background. Again, close to 2 million individuals have a traumatic death annually, and 40% of them related to uncontrolled bleeding. From a resource perspective, up to 50% of rural hospitals lack access to immediate balanced blood products resuscitation. From a pre-hospital standpoint, we're going to be really touching on a lot of that. Blood is logistically limited at times. We may have great providers, and we have great systems that allow us to have that blood on board, but how much do you have? Do you have whole blood? Do you have the things that you want to adequately resuscitate these patients? And again, a large percentage of those are not available. And then vasopressors potentially, in a very small subset of these patients, could be a potential solution for a resource-limited setting during transport. So from a physiological perspective, we have this endogenous cascade that's going to go on. We're going to have an initial catecholamine and vasopressin surge that creates this transient vasoconstriction. What it does is it makes you feel good about yourself. It makes you feel that your patient is going to be fine, and you can kind of just sit back and enjoy the ride, or we can get this patient to CT immediately. This particularly is going to happen in a lot of our younger patients because they're going to have a baseline of these catecholamines to be able to release, constrict, your blood pressure looks nice, and you're happy. But about 30 minutes into that, vasopressin is going to be depleted. It's going to lead to vascular tone, loss of vascular tone, and falling maps. And acidosis and nitric oxide overproduction then cause catecholamine hyporesponsiveness. So these are many things going on, and we're not even considering the cascade from a clotting perspective. This is just what's happening from a blood pressure perspective. How do we leverage some of the therapeutics? Based off some data, the traditional dosing of vasopressin at 0.3 or 0.4, depending on your institution, has been known to restore the tone even in acidosis. Norepinephrine, with its alpha-1 venoconstriction, actually does a pretty particular good job of having shift stress volume centrally. So there's a lot of times we would do a passive leg raise to see if our patient will be volume responsiveness. Well, norepinephrine is in itself, in my sense, a passive leg rate because it constricts that particular part of the body and those particular subreceptors very efficiently to be able to cause you to have what I say about a 500 cc bolus of blood that's resting there. What the goal again is going to be to maintain coronary and cerebral perfusion pressure doing this hemorrhage control. So I don't like to be overly boring. I like to always have a case that comes along with it. We got the red Honda on I-85. So our patient's a 29-year-old male with blunt torso trauma. When you guys get to him, his systolic blood pressure is 58 over PAL. Heart rate's gonna be 142, and his GCS at the time is 14. We transport this patient, we get him, and we get an ultrasound at the fastest positive. So we go ahead and get started. We get him some blood. We got 4 units of PRBCs, 2 units of plasma, and we give him a gram of TXA. Now, this is where a decision point comes in that you guys actually go through every day that you might not consider. And most of the time, I know you're going to lean. Do I start our vasopressor now? I don't know. A massive transfusion after massive transfusion protocol, or do you never do it? So I want to pause and just get a poll of the audience with that patient with the limited information that you have that I really want you to think about in your particular setting. What would you do? So would any of you start norepinephrine now? You can raise your hand for A. Didn't think so. Would any of you guys potentially start a low dose of vasopressin after you've given 6 units of blood? Got a couple more. Okay. This is where I'm going to see most of the room here. For C, would you hold off pressors until surgical control? Good bit there. And then D, never give a pressor in active hemorrhage. That's what I thought was going to be the majority of individuals. And that's the dogma that I want to tackle today. And I may not change your mind because I don't know if I have deep data to change your complete practice. But what I'm hoping to get out of this presentation is for you to even consider what patient population and when would it be an appropriate time to start a vasopressor. So just to give you a quick snapshot back to your norepinephrine, again, it's going to be that potent alpha-1, going to have modest beta-1 activation as well. And this is what I spoke of earlier. At your traditional doses, again, around 7 to 10 mics per minute if you're that way. If you dose it in mics per kilo per minute, around 0.1 mics per kilo per minute, it's going to get you that venous squeeze that's going to be very particular to norepinephrine compared to other alpha-1 agents. And the onset is going to be fairly quickly, less than a minute, you should see your response. Vasopressin is going to be that V1A receptor. It's going to mediate pH-independent vasoconstriction, which is going to be nice. You're going to have this venoconstriction increased preload with minimal chronotropy. And animal data says that, again, this could potentially have renal perfusion preserved and AKA markers be reduced. So you may get that added benefit to it as well. Some of the other agents I won't get too deep in because I don't really think that it's going to be as big of a impact based on the data I'm talking about today. But epinephrine, you're going to have that mix back. You're going to increase your MAP, but also increase your heart rate. And with its beta-2 stimulation, going to cause its own type 2 lactate release. So you have your own lactate due to the perfusion issues you have going on, but the beta-2 stimulation of epinephrine is also going to cause an increase, and your lab's going to read them all the same. Phenylephrine, I think, is going to be an agent that's intriguing. I have it in my pocket right now. Phenylephrine is going to be a mixed alpha, limited trauma data. I'm not going to hold you too much from it from an infusion perspective. A lot of us like to have a Neo stick available. If you guys are on the truck, do you guys have Neo sticks with you? Yeah. So again, a lot of people will have them. I call it just something to have in your back pocket just in case. It makes you feel better. Obviously, I have it in my back pocket. So. And dopamine, I think at this point now, I realized that we're kind of shifting from that perspective. But dopamine was a premix. It was easy to get. It was easy to dose. It was easy. The data just has not sustained with it in any type of shock. I definitely not going to entertain you with that information today. So we're getting a little nerdy here. We're getting to some micro circulation and tissue perfusion. Again, norepinephrine and fluids have been shown to preserve intestinal microflora in rat models. Vasopressin, of course, have improved renal mitochondria in porcine models. And from a micro circulation standpoint, there has been some shown that we have improvements in those actually may be key to organ dysfunction. This is where we start getting to more academic. This is not something that really going to be clinical in nature. But again, when you start looking at some of these other markers and monitoring, some of these tools that we've studied, particularly in the ICU setting, have shown a decrease in 90-day mortality. And you potentially can avoid some cryptic shock where your patient looks phenomenal in front of you. But again, most of us in the ED in a pre-hospital setting won't have access to these tools. I mentioned this solely for academic conversation. So this is what I have for you today. I have a couple of studies I want to go through because prior to, again, 10 to 15 years ago, we didn't have any trauma-specific data related to vasopressors. We have a few cohort studies I'm going to breeze through, honestly. Then we have some meta-analysis that we're going to dive into. So this is the best that I have, the avert shock RCT. This is a trauma study that had 100 patients that already received 6 units of blood within 12 hours. What they did was very interesting, and I stole this. And some of my nurses that work with me, they realized that I stole this particular dosing for different types of shock. Again, they're going to give a 4-unit bolus. Most of the time, we're not going to do that, and this is something that's been pulled from anesthesia. This is like their third, the fourth, or fifth agent they use in their cocktail of ephedrine, norepi, phenylephrine. They gave a bolus. Again, if we're talking about the bag that you guys used to have, a 20 unit per 100. They're basically going to give close to about, again, from 5 to 10 cc's around that amount to get to this component, because you're going to have that 0.2 unit per ml. So they're just giving bolus of that, but again, you can have a significant amount. Prior data, again, has that dose, that bolus has ranged from 0.4 all the way to 4. So again, the bolus number isn't necessarily as important, but they give a really big dose up front. And then they started the traditional infusion for 48 hours. The primary endpoint, what they looked for was the blood products at 48 hours. And it was powered, again, what they got those 100 patients for was particularly to this outcome. So what they find? Well, they dropped their blood product infusion by 50%. That's what the study was powered for. That's what they was looking for. And I can ask myself, if we can reduce the amount of blood that we give in any setting, we have a ton of patients that need it. So this is a really good outcome for me, but I'm gonna be honest, that's not the end game that we're looking for. We're looking for mortality. And what I was nervous to look through, I looked at the primary outcome, I said, okay, this is good. They're gonna like this one. I looked at the second, I was like, what is mortality gonna say? Because mortality is gonna be the thing that all of us care about. And there was no difference. What I thought that could come up was that these patients actually did worse, because that's what I was always taught. Jimmy, if you recommend your little lousy drugs here for this trauma patient's gonna die. That's what I got. And part of that, depending on the patient, that still may be true. ATLS is blood. Absolutely. We gave blood. We got the cooler coming from the blood bank, and now we're in this weird spot where we're not necessarily stable enough to get into CT. You have a positive fast again, but you have a patient already in the OR and half your team is there. Can they hang out in the ED for a little bit, get themselves some more product before moving? Or you're in transport, you ran out of your blood, you only have 6 units with you. What do you do now? This is where I think some of these things come into handy, and knowing that my patients don't do worse, that they can have less blood product, it at least makes me consider it. And that's what happened. An interesting thing that I didn't consider was all the other adverse effects. There was a 68% reduction in DVT risk. That's pretty impressive. And then when it came to other adverse effects, there was no difference in arrhythmias. I really didn't expect that. AKI was no difference there. But more importantly, what I was expecting to see was gut ischemia. Because again, with large doses and over a longer period of time, you can have the peripheral ischemia, you can have the gut. I'm going to also mention, this is great. I'm happy about it. But let's be honest, this study was powered to discuss blood transfusion. So I'm going to hang my hat on that and say that in a smaller population of trauma patients that got the medication that we were looking for, they didn't do worse off. But this is mostly young penetrating traumas. So I'm going to caveat it to that. Again, I've mentioned over and over again the Cisco power. Again, underpowered for mortality, but the safety signals were slightly reassuring, to be honest. From a clinical application perspective, this demonstrates that there is a rationale for us to even consider a lower dose vasopressin with balanced transfusion. Again, keep the things you're already doing. When you get into a spot, you say, oh crap, this may be something to consider. And it suggests that it may, again, reduce transfusion requirements without harm. So that's what I took away from this particular study. It's the best that I have. I don't feel great saying the best that I have is a 100-patient study. So I'm going to be honest about that and say this is exciting. It was well done. We finally got through the component of where we looked at the same type of patients and gave them an intervention, and we gave them a placebo and see what happened. That's not what happened with most of the observational data. Your patients are super sick. They end up getting a pressor. They end up dying. Pressors are bad. Patients not as sick, don't get pressors, get 2 units, go to the step down. Oh, pressors not there is good. That's how a lot of those studies were done before. So I want to make sure the caveat, again, small study, but I also want to caveat the fact that the prior ones, the observational ones, those patients were sick. And Jesus could have been in the OR and it wouldn't have. So prior to this one, another study looked at this was they had a slightly different patient population. This was Cronin and colleagues in 2011, and they had 68 hypotensive patients, and they gave them a 4-unit bolus of vasopressin, and then they started an infusion. All that means is that that's 0.04 units per minute. That's going to be your 2.4 units per hour, but it did it on a smaller period of time at 5 hours. They did see a reduction in fluid. So whether you have crystal lowered or your blood, they did see a reduction in that. And again, they seen a trend towards decrease early death. That's where most is going to be your 24-hour time. They've seen a trend towards that. I don't want to get too that, but again, I had something that says no difference. I had say reduction potentially. I feel better about it not causing harm in select patient populations. And from an organ function perspective, the 30-day organ failure was similar across these groups. So again, when we start looking at kidney function, lungs, seeing all these different things that we're looking at in these more ICU-centric studies, there is no major difference there. But again, 78 patients. Jimmy, calm down. Your drugs can be where they need to be. So when comparing all of this, what we saw is that we have a reduction in transfusion with a relative risk of 0.8, so a major reduction. Mortality is going to be neutral. And then we start looking at some other studies, early norepinephrine versus none, there was a hazard ratio of 0.995 for 24-hour. Again, this was weighted. So again, not a slight reduction there is observational studies. And then we're looking at vasopressin versus norepinephrine. I don't have a ton of trauma data. Again, I don't have a ton of that. Again, I have a lot of others. But again, when they start doing these meta-analysis, the advantage was lost after a lot of the adjustments in these mixed ICU populations. So that's what I have in some more limited studies comparing those two agents. These are questions that came up. So switching gears here to something that, who was practicing when the term was leave a fed, leave him dead? Or has things changed? And my little buddy right here, good old norepinephrine, has made a big comeback. And this study done by Gauze and colleagues was looking at early norepinephrine use. And what they found was that in a larger population, about 2,000 patients in blunt trauma, early norepinephrine was not harmful, and those patients in the norepinephrine group received less crystal lower and reached the OR faster. That to me that's valuable to me. I'll take mortality, I'll take a few other things, but give my trauma team a chance to get in there and get something done. And for me, again, having a larger patient population, no difference in mortality, again, less crystal lower stuff that was given, and then time to OR being smaller. That to me is something that is not necessarily as patient-centric, but it's clinician-centric. And that matters a lot to me. So now I'm looking at all my data, I'm saying, hey, when we start actually looking at and adjust these patient populations for how sick they are, maybe there's something to be had for these drugs. I'm going to argue and say epinephrine for me is just going to be last line. Limited data out there. I know sometimes we do it in these weird pitches where it's like ATLS/ACLS, and we're doing CPR, but should we do? And we're doing different things. It's challenging to find a data that can give you a good answer. So I'm not going to make a recommendation or even try to push this that epinephrine is the same as some of the others, because from a mechanism standpoint, it just doesn't work. It doesn't have that weird alpha-1 subreceptor component that norepinephrine does. It doesn't. It's not going to be something like have vasopressin is going to be maintained in acidic environments. It's not that. So I won't push this on you. There's a risk of a lot of other components that I won't dive into. And it's a role for some of these patients when norepinephrine is exhausted, but these are more your patients that had a medical event that just you found on the side of the road with no damage to the car, and you're going to work it. So that's where I would say this is third line for the medical ones that you just have to be taken care of. There's some other things coming out that we're probably 10 years from. Angiotensin, I particularly think this is the best vasopressor that we'll have. It's expensive, so my boss would not want me to tell you guys it's a great agent. There's going to be a lot of limitations. It's going to be hard to get it on the truck. The titrations, it's tough. All that being said, I think it's one of the better agents that's out there. It's been in the pipelines for a while. We're using it for refractory vasoplasia. Again, no trauma data for you guys now. Mentioned push dose phenylephrine. I think it's there for a patient who you intubate. You know that intratract pressure is going to be mostly due to your drugs, and it's not necessarily completely hemorrhage component. That's where I think it's just to bridge you to the other thing. So I won't necessarily make the same recommendation for phenylephrine, but there's a lot of stuff to look for in the future, and I'm hoping that as my team grows and as the ED pharmacy team across the region grows, these are some of the studies we're going to be looking at. But let's switch gears here. I gave you guys some exciting stuff. Let's see why the people get very upset about vasopressors, because there's a lot of data that says it's bad, but that data is also bad as far as how you weigh them out. There's a Japanese registry. They do it for the Japanese and the Chinese studies. They can get a ton of patients. So they got a very large database analysis that looked at those patients that got vasopressors that was adjusted have like 2 times more increased mortality. That's bad. Again, their shock in those things that the shock index is higher, the base deficit was higher, the injury score is 25. These are sick patients. These are like your patients from the military. These are sick patients. But again, these findings are likely confounded by the indications. And we see this every day. Your sick people get sick stuff. And you throw that on them earlier. So when someone not as smart like me can go and studies that and say, oh, this patient died and they got vasopressors. Vasopressors are bad. That's how a lot of this stuff was done. There's a few other systematic reviews that tried to look at trauma specific. Holly and colleagues had a 2017 review. Again, they found, very low. They mentioned very low quality of data, no mortality signal detected across a lot of these studies. And then the heterogeneity of these populations were just horrible. So it's really hard for us to really put that label on it if we're just being evidence-based. From, again, ATLS standpoint, I get it. I understand the rationale, but when looking at data, it's not as great. Then we looked at some animal studies because I'm nerdy like that, and I go look at animal studies in rats and dogs and do my pet therapy with data. So they found that vasopressin or teripressin, which is more commonly used in the European natures, they saw a reduction in mortality. Again, they found some strong protective effects in controlled hemorrhage models. Again, but the translation in human are uncertain, so I won't make that as something that we should look at. Looking across the guidelines, some of the European studies for hemorrhage, and the problem I have with looking at some of these guidelines outside of ATLS is that it gets very particular with the type of hemorrhage, the type. But they mentioned after getting blood, after source control or understanding where that is, the European guidelines said they wanted norepinephrine first and consider vasopressin. I'll tell you my personal opinion after that. Some of the pre-hospital component, they said there's no routine use. There's pre-hospital pressors focus on hemorrhage control. And then when you start getting to very hospital specific, most level 1 centers are developing protocols or trying to have an understanding. But realistically, from my practice, it's attending specific, depending on what they think is going on. Because what happens is we don't have as much data. We say, I feel shock. The spinal shock's in here as well. I think it's a little bit of this. I've given six units. I'm feeling we can go ahead and add this on. So I don't think we're there yet when it comes to it being protocolized, but that's why I'm having this presentation so we can protocolize it. And I just wanted to make sure I'm being all the way complete with a diverse effect landscape of all this, the gut ischemia being something we have to look for. This is going to happen as you kind of transition from your pre-hospital ICU phase. This is where we're going to get into problems of having the fingers getting cut off, you're having some gut issues. We have some tachyarrhythmias that can occur with epi, a lot more so than norepinephrine. Coronary spasm are rare with vasopressin. In a metabolic standpoint, there is this hyperlactinemia that masks shock resolution. So you actually can be doing a good job of resuscitating your patient, but you decide to give them epinephrine after Jimmy told you don't give epinephrine, and your lactate is increasing every time you do your point of care. It's going to be independent of what you're actually doing, and I think that's something that get missed. But when you have a sick patient, you can't sit back and say, well, is this epi that's causing the lactate? Is this patient shock? You don't have time for that. For me, I personally recommend just avoiding it. Because for the most part, norepinephrine can get you where you want to. And in these patients, I believe that vasopressors can get you there. And I've dived deep into this component. Again, gut perfusion being something that there's no data in trauma patients. Again, in one of the prior studies, we did see a reduction in DVT, but it's about 68%, which I can't ignore, to be honest with you guys. 68% is pretty significant. And then from administration, once you start getting to higher doses of norepinephrine, we would like for you to put central line. We would love for you to do that. But I realize that's asking a lot, depending on the scenario. You want to place a cordis to give your blood. If you don't have access, you want to get an A line. There's a lot of things that's going on. Again, I would like it, but again, that's probably, we always say that's an ICU problem. So, and just continue to monitor these patients. And then as we continue to go through from the metabolic and coagulation standpoint, I've mentioned that over and over again. But another part is that catecholamines actually impair platelet function. That's something that we don't think quite a bit of, and we're going to be giving a lot. If we're going to give a lot of this, and you say, Jimmy just convinced me to give all the pressure. There's some things we have to consider here. Catecholamines does just do that. Again, we've mentioned high dose pressures may worsen acidosis, and then we start looking for things to do. Just monitor these patients. Again, we're going to be getting these repeat labs pretty often. Again, limit epinephrine, prioritize the two big ones, and just aggressively control the triad of death or the diamond of death. I presented last year on adding some calcium. If you go get a cooler and you've been given a ton of product, especially if you're giving PRBCs and not whole blood, check a calcium. If it's less than 1.2, get some calcium. And some gluconate versus chloride. We don't have the data to say which one's going to be better. I know we've talked a little bit before in the past about you need the liver to activate the calcium from the gluconate to make it work. But again, most of the data doesn't see that correlate to actual clinical outcomes. And all of this is going to be very detailed on the patient. There's going to be some special populations, such as your geriatric patients. You're going to have some vascular stiffness, and beta blocker use may require you to use a slightly higher dose. That's something I'm always considering. You have a patient that's 60, 70 years old, their heart rate's in the 70s and 80s, but they're sick as crap. Most of the time, they're going to be on a beta blocker, and you have to figure out a way to kind of overcome some of that. From a TBI perspective, this is where I think it's mostly challenging, to be honest with you. Maintaining the blood pressure that you actually need versus the traditional, just map 65, or let's just get them somewhere. If we can optimize that blood pressure, this is where I think some of the pressors and the blood combination may be beneficial, but we have to kind of look at that, and we may, increase a lot of these things. So we have to just monitor it and understand what's going on. But again, there is lack of evidence, so I can't really push that too hard. From a pediatric standpoint, I mentioned it because we have pediatric pharmacists, and I always say, I'm going to tell you what I don't know. Always ask them. Again, the hypotension is usually a late sign, and they usually compensate quite well, and it may mask the shock. But so you have to be aware of that. Limited evidence. I'm talking case reports, case series. There's a lot of research needed because their PK is a little different, and the long-term developmental side of things is very different as well. So I won't make any recommendations from this presentation. It's solely for adults. So I repeat that. Any recommendations, any data that I spoke of today is going to be mostly, again, all the data is going to be for adults. I don't make any recommendations on pediatrics. So when looking at this, the overall component of this, what do vasopressors do? Again, they're going to reduce transfusion requirements. I feel pretty confident about that statement. Provide centralized perfusion of vital organs. I feel great about that. It's a bridge to surgical control, and it reduces crystalloid administration as well. There are risks. When looking at the data in well-designed studies, these risks are minimal, but potential tissue ischemia, cardiac arrhythmias, masking ongoing hemorrhage, which is the number one thing my surgeons tell me. Hey, Jimmy, I need to figure it out. It's like, well, you got a positive fast, you have the entry to air, we got a CT. Again, we know there's hemorrhage. And I just want to get you to the OR in the best possible shape. And there's a false assurance of a normal blood pressure when something should be done. That's why I say this is really going to be something that we do after plasma and PRBCs and never instead of. So I want to make sure that's clear as well. So we can continue looking at this just to kind of wrap up the presentation. From an education, sim, and quality, of course, team training is going to be great with interdisciplinary sim, kind of looking at some of these patients that are hypotensive that may require a pressor initiation. That's where I think this may start. I don't think this is something that's going to be prime time to your patient without talking to a lot of people, but seeing what those patients look like when you're training and going from there. Then quality monitoring. If this is something that we're going to be looking at, what happens to the time pressor? How many units are transfused? What is their AKI risk? Actually starting to collect this data to see what is actually going on. I think when we have a combination of us trying this and studying some of these effects, that's when we can probably move to the next step. Again, from my standpoint, for the pharmacists watching and that's around, again, pharmacist-led events, again, a post-event debrief after cases, saying, like, hey, why'd you recommend that? If you have time. I realize that, again, some of the team goes to the OR or you guys are going back on a truck, going back on a plane. But again, why did you recommend that? So for people who's recommending that, we should be telling you why. And then protocol refinement. I think this is where we should start to getting things together and understanding when we should start to add these in. So let's come back to our patient. Again, he's looking pretty happy right now. He got some vasopressin at the standard dose of 0.4. And you notice I didn't do the bolus here because, again, I said that my provider said no. And if not, went up to about 7 minutes. His lactate improved in a couple hours. Again, they went to the OR and took care of him about 45 minutes after arrival. Pressors at 6 hours. He had a 3-day ICU stay and no VTEs. So picture things. What I want you guys to take away from a lot of this is that I feel very confident saying that vasopressin it actually reduces the amount of transfusion requirements. If I can reduce 50% of the entire region's blood supply and use it for other cases, I think many people will be happy. And I think that we can use that product for other cases. I feel slightly better saying that early norepinephrine is potentially safe. In particular populations, my recommendation kind of drops off pretty tremendously for norepinephrine. But again, the data that I found that said that starting it earlier, when you control for sick versus sick, it may be okay after using your product. I caution you from using the epinephrine. I've tried to get through this over and over again. I don't think it's a great drug to use in this scenario. Ischemia, risk management, again, it's going to be rare with the lower doses of vasopressin, but realistically, there's a lot of data that we need for me to feel very confident in this for a more protocolized, more systematic approach for every patient. We need large norepinephrine versus vasopressin studies that's powered to detect some organ dysfunction and mortality. If we can find a study that says that we actually have a mortality benefit, I think some people are going to need to, especially my old school docs. So Jimmy, let me tell you something. I'm never using that. If I get a study, if I conduct a study that shows some mortality benefit, I don't care if it's at 2 hours, 6 hours, 24. You're going to hear me scream from the top of the moon to do this. But we're not there yet. And I'm going to be honest that I need a lot more research to get that taken care of. And this is kind of the cascade of different research to look at. Again, randomized controlled trials can be great. Special populations, looking at my geriatrics and my pediatrics, advanced monitoring. That's something we touched on earlier. But what is this microcirculation stuff really? How does that work out? And can I do it pre-hospital? Can I do it air? Can I do it in ED? Do I collect blood, send off to the lab, and then people downstream in the OR can manage off that, similar to like what a tech can do? These are a few things that I want to look at and see studied. And from a pre-hospital standpoint, again, feel stable, push those vasopressor trials for sure in these weird environments. So I personally think that if you had a neo stick and a vasopressin stick, and we're giving this 0.04 as a push, my vasopressin is going to work pretty quickly as a push, and it's going to last for 20 minutes versus your phenylephrine can get you about 5 to 10 good minutes. To be honest, push those epi. For a while, it was like really, really, really cool and everyone was doing it. I feel like it's that phase kind of died off a little bit if you don't have the pre-mixed epinephrine. So it's a few things that I think we need to study and look at. There's a lot for everyone in the room, whether you're a provider, whether you're a nurse, whether you're pre-hospital or the ED, whether you're the OR. A lot of these therapies can be applied there, but we need a lot more data. So my key take-home message: the smallest effective pressor dose after balanced blood. Blood first, vasopressin adjunct, maybe norepinephrine, epinephrine never, is going to be what we should do for some of these patients, and I think we should look at it in greater detail. So I had a few things that I want to kind of get set up. Again, I want to make sure from a pharmacy perspective, we stock these vials and have it available for you, because it sounds great, but if it's not there when you ask for it, none of this makes any sense. Having something from an EHR standpoint to make sure we have like order sets with weight defaults and hard limits can help out. Pharmacists being available at the bedside to get these things prepared and get it set up while you guys are getting IV access, while we're getting blood, resuscitating the patient. We need to make sure that we're there to augment you. And if you don't have a pharmacist at your ED, make sure you ask for one, because it may change the way you look at things. Because I always say a pharmacist in the ED is like a grocery store. You don't need it, but it sure as heck convenient, right? So I mentioned a lot of the limitations and controversy. Again, studies are not great. Statistical issues to look at. And from an ethical consideration, again, randomizing pressors and parameters poses some ethical challenges that we have to look at. All right, so I'm going to pause here and be able to take on any questions that you guys have. And I'm excited for everyone to come. So thank you for allowing me to come and present for a good remainder of your day. But I'll answer any questions before I get you guys out of here.
I know this is a trauma-specific conference, but when you think about ambulances and our limited space that we have, and the fact that 85% of our patients is not a highly acute patient, so we always have to be cognizant of staying fresh in our skills.
Mm-hmm.
Of the vasopressors and norepi, when you're looking at different kinds of shock outside of traumatic shock, which of those two vasopressors do you prefer for all kinds of hypotension?
Yeah, so the question for those that's listening is, in a limited setting, in a pre-hospital setting, which vasopressor, norepinephrine versus vasopressin? I'm gonna say norepinephrine, because it's gonna do everything. And I teach people it's never wrong to use norepi. So if you have a cardiogenic shock patient, you can start with norepi, add dobutamine on top of it. It's everything. So it's like there's not a reason where you should take norepinephrine off the truck. Where I want to kind of caveat this is that I want to find data that you can use norepi, but that's kind of be the more clinical thing that we're going to shoot for. I would say from a data perspective, I have more data for vasopressin. So when it comes to that, in my setting, I can use both pretty quickly. In your setting, if you have norepi and if you start 7 of norepi on every single one that's hypotensive, I think you'll be fine for that standpoint to get them there.
In the studies that you showed, or you mentioned, 6 units, is that like a standard number? Is that whole blood? Whole blood, is that how many PRBCs? Is that 6, and is that a full MTP?
Yeah, when they looked at it, it was 6 units of product. So again, most places of using, again, that's why I put in the initial study, you had 4 PRBCs and 2 of plasma. That's gonna be a total of 6. So most of those studies try to categorize it, because again, I think it's a great thing now that we're switching towards whole blood and we're doing things a little differently to caveat it. But the initial one is 6 units. So when I say we can save the patient 50% of that, the way I look at it is I do everything in coolers in a sense. So you're going to have all those things there. You're going to take back a cooler every day. So that's the way I thought about the number of product that I'll be using over a period of time. Because the study looked at, it was 1.4 liters. And then it was like 2.9 liters was the placebo group. So looking at, again, correct me if I'm wrong, the products are usually anywhere from 300 to about 450, depending on if it's whole or if it's going to be just a traditional product. So that's going to be the reduction that we saw there.
What was that last 2 number?
Oh, so again, if you're saying that, do we agree that around 300 mLs is the amount of product?
Right, but what was it that they needed?
No, I was saying like that was the reduction. Because we looked at it, the outcome was in liters. So it was like basically 3 liters versus 1.5 liters. So that's how I started to make it to where we had, I can go back to that slide there.
I'm just thinking our emergency release, that just comes with the patient, right? Is 2 and so those are those 4 units. So could you make a clinical decision? Is that enough to make your next?
It's tough.
Only at 4.
Yeah.
And then our next step is to order NTP. that's where I was kind
The,
of wondering about the volume.
this will be kind of my recommendation for it. I would say whatever you have in your cooler immediately, once you use that and you're on the way to get an MTP, if you don't already have one, that's where the bridge is for me. That's that point. And that's usually around 6 units of something. And that's where I would say that's the concern point. That most people, when you start asking for a cooler, it's like, okay, some places I work at, it automatically comes down depending on the level that you're gonna have. But those, when you use that amount, that kind of raises your level of concern about what we should be doing next. That's where I think that in limited patients, that may be the point where vasopressin in hospital may be a benefit based off this data.
One more question. Did any of your studies come out with, if any of these were more neuroprotective? I know that's a difficult question to answer in trauma, especially if it was, a traumatic brain injury, but we do find that there's some studies out that are saying that these vasopressors can be neurotoxic. Is there anything that you saw across these studies?
Not these, and even some of the observational ones, they became challenging because, again, some of these patients had brain injury to begin with. So that's where I say it became challenging to figure out how these can be neuroprotective. You have to screen those out and have a particular study just for those, and then still randomize them to get agent versus not. But these ones looked at more, again, the big picture things, the ischemia, whether these patients had arrhythmias, and those having different type of VTEs. All right. Well, I thank you guys for joining this presentation. Hope you have a good day.